Hello, I'm Dr. Brian Cole from Rush University Medical Center in Chicago, and this talk is on why we should always place a posterior inferior anchor during shoulder stabilization procedures. There are some general decision-making principles, including the issues of recurrence, worsening pathology over time, documentation that early surgery is probably better, and it might even prevent the progression to arthrosis, and whether it's open or arthroscopic procedures, it often works to stabilize the shoulder. However, with recurrence, we know there's worsening pathology. Certainly, single dislocations might be associated with acute pathology and may be more optimal for arthroscopic repair. But historically, it becomes more challenging and may be more optimal for open repair when we have bone loss or inferior tissue quality, especially with inferior glenohumeral ligament deformation. We know that as pathology worsens, recurrence rates are higher after shoulder stabilization procedures, as has been demonstrated by Olivia Harris, when patients had greater than 3 dislocations prior to surgery, especially when younger than 20 years of age, they had worse outcomes following stabilization procedures. There's an abundance of data that shows that early surgery is generally better. And in fact, acute surgical stabilization is more effective than conservative treatment based upon recurrence rates and return to sports, especially for patients less than 30 and at-risk sports. So how are we really doing? Traditional literature has shown us that in systematic reviews and meta-analyses, that in general, open versus arthroscopic suture anchor placement shows similar recurrence rates. However, when we look at the literature more carefully, especially over decades analysis, in this study, evaluating 22 studies, in the period of 1995 to 2004, open repair was actually better than arthroscopic. While they were somewhat comparable between 2005 and 2015 in the entirety of the literature, there still was a trend towards higher recurrence rates with arthroscopic stabilization at about 15%. So we have to ask ourselves, are we really comparing apples to apples or apples to oranges when we look at the literature? And in fact, the literature is very heterogeneous. When you look at arthroscopic reports, there are comparisons between knotless and knotted anchors, the number of anchors, whether or not bone grafts are present with or without rotator interval closure, and inclusive or excluding posterior capsular reconstruction and repair. So can we do better? Traditionally, open medial-based repair procedures routinely address the posterior inferior capsular pathology, and traditional arthroscopic repairs addressed only the anterior inferior pathology. It was Russ Warren who introduced the circle concept in the early 1990s and published with Peter Trozili the circle concept, investigating the capsular restraints to anterior posterior motion of the shoulder when it was abducted at 90 degrees. Here they reinforced the hammock concept of the inferior glenohumeral ligament complex. And they showed a relationship between the anterior and posterior capsulolabral complex and shoulder stability at 90 degrees of abduction. Specifically, anterior fixation led to translation of the shoulder posteriorly, and adding posterior fixation actually balanced the shoulder. Inferior anchor placement has been looked at by a number of authors. In this cadaveric study, there was a 16% increase in peak resistance force when a 6 o'clock anchor was placed, even when there was critical bone loss present. Adding a posterior inferior anchor in this study showed that there was minimal risk of intersection when placing both a 7 and a 5 o'clock anchor. This is a study from our institution in 2014. In a series of revision patients after failed shoulder stabilization procedures, all patients had a posterior inferior capsulolabral repair included. Most improved with PROs, and there were only 5 failures due to recurrent instability in this challenging population. So how do you get it done? Certainly lateral decubitus over beach chair position, in my opinion, is much easier. With balance traction, balance suspension, you can get easy access to the posterior inferior capsulolabral complex, as you see here. The 7 o'clock portal has been investigated and described by several authors. Tony Romeo described it in 2010, and we showed that curved drill guides did the same as straight drill guides. You can see how a 7 o'clock portal, as shown here, allows easy access posterior inferiorly and anterior inferiorly, and can complement traditional portal placement in the rotator interval. So how do you get it done? Arthroscopically, this is an example of a patient in the lateral decubitus position. You can see a very straightforward anterior-inferior labral tear. Ascribing to the circle concept, we prepare the posterior inferior capsule using a rasp. We then use a suture lasso or a suture loop at 45 degrees, in this case to the left. We shuttle the suture posterior inferiorly and retrieve it through the 7 o'clock portal. This portal allows us to get on FOS to the edge of the glenoid or even on the face of the glenoid to dock the posterior inferior capsulable tissue. And then we proceed with anterior-inferior stabilization procedure with 1 or 2 additional anchors typically. Here you can see the final repair with the posterior inferior and anterior inferior anchors placed. So the bottom line is the circle concept is supported biomechanically and clinically. And for arthroscopic stabilization to be routinely as good as open stabilization, repairing the posterior inferior corner will help restore and maintain normal glenohumeral translation while minimizing the chance of recurrence. It is technically easy to perform, and there's probably no downside. Thank you very much.